He's been on the faculty there since 2002 and currently is an associate professor with appointments in the Department of Biostatistics and Epidemiology, as well as dermatology. He has assumed numerous leadership positions in the areas of dermatoepidemiology, both nationally and internationally. And he is a member of the Institute for Translational Medicine and Therapeutics at Penn, as well as the National Institutes of Health Research in the United Kingdom, frequent reviewer at the NIH and for the VA. He has authored numerous meta-analyses that are important to dermatologists in practice, and the dermatologic therapy has been impacted by much of the work that he has done. He does comparative effectiveness studies, as well as numerous dermatoepidemiology studies that have ranged from diabetic leg ulcers, venous ulcers. He's done work on complementary and alternative medicine and hidradenitis. His main area of research is psoriasis, and the work that he's done, I think, really has changed the way that we look at psoriasis, and dermatologists and cardiologists certainly have been impacted by the work that he'll be telling you about this morning. I think it may change the way you counsel your patients on cardiac risk factors. So I would like to welcome Joel Gelfand as our lecturer. He'll be speaking at the Seattle Tennis Club tomorrow afternoon, where he gives the Adlan lecture, but has been kind enough to give us medical grand rounds. Welcome, Joel.
Thank you, John. That was a very kind introduction. I realized that hearing all that, I realize now I feel tired a lot. It's a lot of work. So I want to get a sense of the audience here. How many of you have heard that rheumatoid arthritis may be a risk factor for cardiovascular disease? Let's raise your hands. So most of you. How many of you have heard that inflammatory bowel disease might be a risk factor for cardiovascular disease? And how many have heard about psoriasis being a risk factor for cardiovascular disease? If you're a dermatologist, arms down. Okay, this is really helpful. All right, so I'm going to talk about psoriasis and cardiometabolic disease, and go through some sort of basic information about what psoriasis is, how we assess this disease, and then go into the media of the talk. As a disclosure, I've been an investigator or consultant for a variety of companies who make products for psoriasis and received grant funding from some of these companies. And this presentation is my sole work. There's no industry slides or content in this talk. So psoriasis is a disease that we've known about through almost all of Western medical thought. It's a disease that was often confused with other diseases, such as leprosy, for example. Gene Van Scott was one of our dermatology heroes. Gene started the derm branch at NCI, NIH, in the 1960s. And as brilliant a scientist as Gene was, he was also the one who showed us that in psoriasis, the kinetics of epidermal turnover are massive. So a normal keratinocyte takes 30 days to go from the basal layer to the outside world. It takes about 4 days, 5 days for that to happen in psoriasis. And this seminal discovery by Gene confused our field for quite a time, because people thought, well, this is an epidermal disease. And all those sort of blue cells hanging out, really just hanging out. They really weren't part of the pathogenesis. It wasn't really until the 1980s that it became clear that, in fact, T cells were critical to the pathogenesis of psoriasis. In the 1990s, where that was sort of definitively proven via a variety of human experiments. And now we have this emerging concept that, in fact, psoriasis is more than just a disease of the skin, but in fact, it's a systemic inflammatory condition. I want to go over some basic epidemiology, make sure we're on the same page here as we think about this disease. So psoriasis is extremely common, affects about 2 or 3% of the adult population. It's more than 7 million people in the US, more than 125 million people worldwide. There could be some differences in the prevalence of disease by different races and ethnicities, but it's seen essentially in all communities all across the world. So it's a little less common in African Americans, for example, but still common. And there's been strikingly little work understanding the burden of the disease in subpopulations. So, for example, our study is one of the few to look at the prevalence of psoriasis in African Americans in the United States. There have been no other population-based studies looking at this. And we found some data suggesting that people with, who are African Americans then have more severe psoriasis. So there's possibly some disparities in terms of how the disease behaves in different populations as an area of further research is needed. Disease severity is a critical issue with psoriasis. So one of the great things about being a dermatologist is that the disease is there to see. It's right on the skin. So we get to see people have very, very mild disease. They have maybe 1 or 2 patches on their elbows, all the way to people who have it, essentially covering their entire body, called erythrodermic psoriasis. So it's important to understand, for the context of this talk, that most people in the general population have mild psoriasis, so about 85% have limited disease, elbows and knees, but about 20 to 25% of patients have more extensive disease. People who may end up going on systemic therapies, ultraviolet therapies to control their psoriasis. So in terms of natural history, most people develop psoriasis in their 20s and 30s, but you can develop it at any age of life. The oldest patient I had developed psoriasis was 95 years old. Imagine when you look at 95 years and she got a horrible case of psoriasis. Actually, around the time of the death of her husband, and in some days there's that major life events could be a trigger to developing psoriasis. Genetic susceptibility is important in this disease, and I counsel my patients about this quite a bit because patients are always confused. Well, why do I have psoriasis? No one in my family has psoriasis. That's because it's a very complex genetic trait. And so only about 40% of patients who have psoriasis have a family history. The odds of passing it down is about 15%. Men more likely to pass it on than women for some of the epigenetic process we don't fully understand. And from GWAS studies, there's more than 20 genes that implicate as psoriasis susceptibility loci, if you will. But HLA-CW6 is most commonly implicated, again, reminding us of the importance of the immune system of this disease. Any part of the body can be affected by psoriasis: the face, the scalp, the nose, the genitals. And depending on what areas are affected, it really determines the burden of disease for the patient, the symptomatology, how much of an impact it will have on their life. And then the other thing that's sort of fascinating about this disease to study is that unlike rheumatoid arthritis or inflammatory bowel disease or other chronic diseases, most people are not treated. So if you have mild severe psoriasis, your odds of having disease well controlled over a period of a decade or two is less than 50%. And this is from our best case scenario, people followed at the top academic medical centers across the country. We study this in a broader population, say people who are members of the National Psoriasis Foundation, advocacy organization. These are people who, in theory, really are interested in the disease. Only about a quarter of them are actually on medications that are appropriate for them having widespread psoriasis. So most people have long-standing chronic inflammation of the skin, and it's a unique opportunity to understand the impacts of this for patients over time. So it's important to understand psoriasis has major impacts on health-related quality of life. It's actually similar to other major morbidities. So if we look at physical functioning, this would surprise most people, but people with psoriasis tend to have worse physical functioning than people with other chronic major medical diseases, whether it be arthritis, lung disease, and diabetes. And then, not surprisingly, of course, is the emotional impairment of the disease, with functioning worse than most of the conditions, second only to lung cancer and, of course, depression. Now, these quality of life studies don't tell the full story. I think sort of from anecdotes or qualitative data helps people understand the burden of psoriasis. How many people have heard of John Updike? A lot of guys. He's not the East Coast guy. Okay, so yeah, he's a famous Pennsylvania poet, won the Pulitzer Prize. And he wrote extensively about his lifelong battle with psoriasis that he developed as an adolescent. And he had this one quote which I find very insightful. Only psoriasis could have taken a very average boy and made him into a prolific, adaptable, and ruthless enough writer. And what he meant by this is that to be able to walk out into the world with psoriasis, on your nails, on your scalp, on other visible areas of the body, is to be subject to criticism all the time. You want to know, why do you have this? What is it contagious? What's wrong with you? And it's a similar thing to be a writer. You're going to write something and people are going to tell you it stinks. You need to have that sort of courage and ability to believe in what you're doing and move on. Now, a somewhat less sympathetic person from history, Joseph Stalin, this is actually the nicest picture I could find of him. He's very aggressive. In every picture he has this aggressive, menacing look. So he also had psoriasis, and this is really nicely chronicled by European dermatologists both. And so basically, he was treated with this sort of alternative therapy. It was derived from animal urine, or it was called lysates. A guy named Kazakow, and he was so impressed by this that he closed the entire State Institute of Skin and Venereal Diseases. So this is about 30 people he just fired, got rid of them, and replaced it with this new institute in Kazakhstan to study lysate therapy. Now, what you all should know about with psoriasis is it's very hard to treat. Even when you get people clear, the disease often comes back, on therapy, and unfortunately, Stalin's psoriasis relapsed, did not respond to repeat episode of lysates, and that led to Kazakhstan being tried and executed. So we all have difficult patients. This is a reminder. Okay, so let's think a little about the clinical features of psoriasis. I want to make sure we're all on the same page here. So, classically, this is a person who has more severe disease, but these very well demarcated, sharply demarcated red plaques with silver scale. There's an enormous amount of angiogenesis in psoriasis that supports this plaque. So you often see these little pinpoint hemorrhages, we call this Auschwitz sign. And as I mentioned earlier, other parts of the body can get affected, like the hand, palmar psoriasis. You can imagine how incredibly disabled this is for people to develop. And as a dermatologist in a large active medical center, the emergency calls are often for surgeons about hand dermatitis and psoriasis, how to manage this. There are other variations of psoriasis. So, if you take all comers, probably 80 to 85% have, psoriasis vulgaris, plaque psoriasis, but there's other things you should know about. There's buttate psoriasis, these very small papules. If you biopsy it histologically, it's very similar to psoriasis. And this usually comes on very quickly, often in the setting of infection, and typically goes away over time as the infection clears, but can progress to plaque psoriasis. Pustular psoriasis, another variant of psoriasis. And again, histologically, it looks like psoriasis is a little more intense with neutrophilic infiltrates. Patients can be systemically ill. They have fever, arthralgia, and oftentimes they need rapid evaluation. You have to make sure they're not septic, it's not infection, and they need urgent medical care to sort of cool this process off. This is less common. And then finally, erythroderma. This is a whole series of diseases and exposures that lead to a patient having essentially most of their skin inflamed. But psoriasis is one of the more common causes of this condition. It results in impaired epidermal barrier. In the old days, people would die of this. Before they had things like topical steroids, prednisone, and things of that nature, people would develop high output heart failure because of all the enormous amount of blood going to the skin. Obviously, with all this inflammation, the skin barrier is perturbed. Infections are the main thing we worry about. So these people show up in the emergency room to keep things and make sure they don't have a septic picture. And then we would cool them off with intense topical regimens of systemic things. And they often have electrolyte imbalances as well. So there's also a differential diagnosis of psoriasis. There's a story behind this sign. So I used to sit in dermatology. So the dermatology wing between us and ophthalmology was family medicine. Okay? And the poor people sat in family medicine all day long, people knocking on the door. Where's the eye doctor? Where's dermatology? All right, so this is a differential diagnosis. It has a sign up, eye doctor that way, dermatology this way. I thought this was sort of apropos of a differential diagnosis for the medical audience. So there are many diseases that psoriasis could look like. And even for an experienced dermatologist, it could be challenging to make the diagnosis sometimes. So it's important to note about this because certain therapies could really do a lot of harm to the patient if they go the wrong direction. So for example, there are forms of subcutaneous lupus and dermatomyositis that look a lot like psoriasis. These are the last kind of people you want to say, go out and get some sun. That can really flare your disease and can lead to very serious consequences. There are malignant diseases like mycosis fungoides, a T-cell lymphoma of the skin, that could look very much like psoriasis and tends to get much worse and progress with immunosuppressive therapy. And then for isolated lesions, patients go, I got one spot here, doc, and they have psoriasis, and you're putting steroids on, it's not going to be better, and it's a squamous cell, or it's a beta cell, you can be treating these things. There are infectious diseases, tinea infections, scabies, syphilis, they're all like psoriasis. A variety of other skin diseases, eczema, theorizes rheumatoid pilaris, like the fungus. And of course, allergic drug reactions are important for that as well. The last thing we want to do is have a patient whose disease could be essentially cured by removing the offending drug by missing. So I think for patients who aren't getting better or not clearing with simple topical regimen, certainly having a consultation with a dermatologist is really critical because patients will live with this disease for a long time. It's important to diagnose right. So then there's a treatment paradigm of psoriasis. We sort of think about the disease as being either mild, which basically means that it's localized enough that topical medication should be effective. And it has minimal impact on your health-related quality of life, minimal disability, or impacts on their emotional or physical well-being. And those patients we usually just treat with topicals, and most of the time they can do pretty well with that. But then we have sort of moderate to severe disease. Those people have more than 5% body surface area. That criteria tends to be because if you think about your palm being about 1% of your body, with 5 palms of psoriasis, it's just pretty hard to put topical steroids twice a day all over your body. And there's studies showing that people with more extensive psoriasis may spend hours taking care of their psoriasis. Most can't do that. And then the impact on your health-related quality of life. So people who may have it just on their palms and soles, or maybe have genital psoriasis, or maybe have bad scalp disease and facial disease, if they can't function normally or it impacts their well-being and social relationships, it may have people to them to have more severe disease. And they're then candidates for everything. So we use topical medications, ultraviolet therapies, traditional oral medications like methotrexate or retinoids, and a medication called cyclosporin, and then more recently injectable biologics, most of the CF inhibitor variety, increasingly these drugs that target the Th17 pathway of the immune system. All right, so we covered sort of the intro. Now we're going to get into sort of meat of the talk, discussing cardiometabolic disease. And so, on the right of your screen is an old ad from the same time for the heartbreak of psoriasis. People sort of thought about disease back then. It was Tiger. And Charlie McDonald published the first article on this. And I said to him, Charlie is still alive. He actually just stepped out of his chair at Brown. And I got to meet with him a couple of years. And I said, why on earth did you study psoriasis and cardiovascular disease? Because there was two things. One, at the time, there was a drug that came out that worked similar to methotrexate. It was very, very effective, but it got pulled from the market because there were spontaneous reports of thrombotic events afterwards. And he said, my patients also have cardiovascular disease. So he did a hospital-based case control study. And they basically showed that patients with psoriasis at their hospital had higher prevalence of venous thrombotic disease and arterial thrombotic disease as well. That literature got lost for many years because no one knew what to make of it. How could these diseases be related to one another? Well, the 1980s came. That's when the idea of Th1 inflammation became central to the pathogenesis of atherosclerosis and myocardial infarction. It wasn't enough just to have cholesterol, but it was how your body processed cholesterol that led to atherosclerosis and ultimately plaque rupture. This is an article, a cartoon from New England Journal of Medicine. And if you're a dermatologist, you're going to say, this is a cartoon of psoriasis. This is the same cartoon we use to understand the immunophenotype of psoriasis, if you will. And this is also one of the major inspiring articles that led me to pursue this work in cardiovascular psoriasis. In the 1990s, I alluded to earlier, Th1 inflammation became central to pathogenesis psoriasis. It basically showed that we took a very specific drug that knocked out T cells at disease inflammation, proving that theory. So the question still remains, though, how do you go from this phenotype here in the center screen, more severe psoriasis, to atherosclerotic disease? They're phenotypically different. And the way I think of this as a clinician and a clinical investigator is these sort of shared pathways that lead to developing psoriasis. So it turns out smoking and obesity, both in the last 5 or 6 years, have been fairly well worked out to be risk factors for developing psoriasis. And then multiple genes have been associated with psoriasis and loci, and many of these overlap with susceptibility to cardiovascular disease, including ApoE4 is a cardiovascular risk gene, CDKAL1 is a metabolic risk gene. Once you develop psoriasis, you are subjected to the pathophysiology. Remember, I talked about the treatment patterns earlier. Most people have the disease for decades without any successful control of their disease. So it's sort of like having an elevated systolic blood pressure for decades with no treatment for it. And so with psoriasis, there's chronic Th1 and Th17 inflammation. We know this could promote atherosclerosis, thrombosis, and lipid metabolism abnormalities. There's dramatic epidermal proliferation, which elevates uric acid. Uric acid is going to be potentially a risk factor for damage to the epithelium, as well as oxidative stress. And then finally, something that's completely underinvestigated, the idea of angiogenesis of psoriasis leading to endothelial cell dysfunction. But one of the strongest correlates of psoriasis activity in the blood is actually vascular endothelial growth factor, and who would have predicted that for skin disease? VEGF being the most strong correlate for disease activity. Then we have our treatment patterns. So some of our therapies, especially the older ones like cyclosporin or acitretin, they in theory can increase cardiovascular risk by elevating triglycerides or increasing blood pressure. Methotrexate is felt to be cardioprotective, at least in rheumatoid arthritis. It is just that lowers risk of cardiovascular disease. And then there's the burden of disease, comorbid depression, alcohol, smoking, psoriasis, and that lower socioeconomic status. And so what we try to do as epidemiologists is trying to isolate, well, how much is a disease versus other sort of third factors that could mediate it. And so this is our first foray. It's an article we published in JAMA in 2006, where we first were looking at myocardial infarction. It was our first endpoint. I want to take you through this a little bit about how we do this work. UW actually is one of the premier epidemiology groups in the world, so it's an honor actually to be able to show this work here. So we use a data source called GPRD, so those who are epidemiologists will be familiar with this. In the United Kingdom in the 1980s, they quickly learned the importance of using medical information for scientific research. And so they created these systems that were validated for obviously clinical care, but actually to truly reflect what's happening for patients over time. Established in 1987. And what's different about this is that in the United States, someone has, you may want to draw blood from someone for check their cholesterol, and you have to put a code for hyperlipidemia. That's not the way it works here. Their codes are actually medical diagnoses. They don't put them in unless they get the diagnosis confirmed. They get audited and have incentives to do it correctly. In the UK system, the data is recorded by the GP on diagnosis and medications. And in their system, everything goes back to the GP eventually. So we go to the specialist, we ultimately go back to GP ongoing file management, having sort of a closed system where everything that happens to the patient gets filed and captured over time. And so large system is, at the time we did this analysis, just 87 to 2002, 9 million people in the system, it's about 5% in the United Kingdom, over 40 million persons with follow-up. And fortunately for us, GPRD has been used by hundreds of investigators around the world for a variety of conditions. Others have validated for MI, smoking, and other covariables. We looked at it for psoriasis. I'll show you how this sort of works. So for us to convince ourselves that a psoriasis code reflected psoriasis, we did two things. We first looked at the epidemiology of the disease in the United Kingdom population from the GPRD and found it was nearly identical to what was previously estimated in population-based studies in the UK. So there's like this convergence validity, if you will. The disease behaves the same in the GPRD settings as it does in the general population. And then we sent surveys to the GP doctors. They get paid very well for this, and response rates are quite high, about 95% response rates. But basically, when we asked about 100 different doctors about patients who had psoriasis codes 3 to 4 years after they had this code, does the patient still have psoriasis? Based on what you know now, they follow. And 90% of the time, that's was confirmed to truly be psoriasis. For myocardial infarction, the way those validation studies were done, this is by other investigators. They basically took people who had the MI code, and they were able to show in the medical record that they had characteristic enzyme changes, characteristic EKG changes, things of that nature. Give into that MI code and that acute myocardial infarction. So this is a cohort study, broad age population, age 20 to 90. In the cohort study, we identified people by their exposure. And for the psoriasis cohort, we called them mild if they hadn't received any systemic therapies or phototherapy for psoriasis. And we called them severe if they received systemic phototherapy for their condition. So we're leveraging the fact that most people in the general population have mild disease, and only a small subset are severe enough to get systemic therapies. And therefore, they get systemic therapy, they probably have that disease. The comparison cohort, people who didn't have any psoriasis codes, and they gave them the same practice and same start dates in the practice. So this is sort of the scheme of how we think about observational studies and clinical trials. And the goal is to sort of make your observational study identical to a randomized controlled trial as much as you can to minimize selection bias and condition bias. So what we do is we have this sort of well-defined population, people in the GPRD database, and all of them are into our study. It's not like they volunteered to say they're in it, it's anonymized data. So that essentially eliminates or minimizes any form of selection bias that we do. Okay? And I should say GPRD is represented in the population. 99% of the population is being cystic likely, so it's not like there's an issue why people are in the system. And so we can't randomize people to psoriasis, so these are our psoriasis patients. These are people who don't have psoriasis, and they're followed by the same doctors, the same practice, same time periods, and they don't know what our hypothesis is, and I'm studying this in the way, shape, form. So in theory, they're almost blinded. Ideally, they're following the patient the same way, not looking for MI, more in psoriasis patients without psoriasis. And then there's also the issue of this imbalance of confounding factors, obesity, hyperlipidemia, diabetes, and that we adjust for in our statistical models. So this is just a table 1 from our publications to give a sense of the population. So about 500,000 patients in the control group, about 130,000 people with mild disease, about 4,000 people with severe disease. Again, reflecting the fact that if people have more severe disease, there's still an enormous amount of treatment. So we know there's some small percentage of people in here have more severe psoriasis. There's some minor differences in sex and age. That's because we have such overwhelming statistical power. Those are things we adjust for in the models. So what I'm going to show you now is the cumulative studies that we've published now, looking at MI, stroke, all-cause mortality, cardiovascular mortality, and a combined endpoint of major cardiovascular events, stroke, MI, cardiovascular. And so these are all adjusted for traditional framing and risk factors. Body mass index, smoking status, and prevalence of other diseases like hyperlipidemia, diabetes, hypertension. And so what you see is people with mild disease see a very modest increased risk of MI and stroke. We didn't see this risk of mortality when we looked at it to these other endpoints. When you get to more severe psoriasis, you see more clinically significant increased risk. So a clear dose response, about 50% higher rate of these events, independent of traditional cardiovascular risk factors. And so when we do these studies, we're constantly thinking about ways to test our analysis to make sure that they weren't sensitive to certain assumptions. So for information bias, one could say, well, maybe they would have followed more closely for MI, which is unlikely but possible. So if we restricted to people who were seen on average once a year, the results are basically the same. If we restricted to people who had no history of inflammatory joint disease, psoriatic arthritis, or so they had to be on a medication called an oral retinoid, which is very specific to psoriasis, not really used for any other therapy, any other diseases for the most part. The results are the same or more extreme. So convincing ourselves that we were identifying people with more severe psoriasis. For cardiologists, there's, as you know, there's about 50 cardiovascular risk factors. Everyone has that data cardiovascular risk factor. You know, we would say, well, you didn't measure homocysteine. There's a homocysteine issue. And so the way we get at this is we use what's called an external adjustment model, where you ask the question, well, how much of a third factor would be prevalent to make our results go away? And here we find that you have a very common risk factor prevalent in 20% of the control group, that's like hypertension. Have a very strong relation to psoriasis, an odds ratio of 2.7. And have a very strong relation to cardiovascular mortality, for example, over 6. And there are no major cardiovascular risk factors like the Davies rates in current time. So it's unlikely that there's a third factor that was completely missed and needs to very completely. We know what the treatment effects. We know that methotrexate can be cardioprotective. We kick those people out. We found that this did go up to some extent. And then we know that cyclosporin and retinoid patients possibly could be more at risk, and the risk still persisted when we put those. So no studies are perfect. This one certainly wasn't. So one is we didn't measure skin disease directly. So I can't really tell you like how bad does your skin have to be before we know they have higher risk of cardiovascular disease. In the United Kingdom, in this time period, methotrexate was by far the most commonly used systemic therapy. About 60% of our patients have methotrexate. And so our risk may be really underestimating what's really going on. It's in fact cardioprotective. We also don't really know how these results apply to people who have bad psoriasis just aren't being treated. It may be worse in that group, maybe better. We suspect it would be worse, but we just don't know. And this is not a mechanistic study, it's just observational research. Let's talk a little about the clinical significance of this disease. So now I'm going to focus on people who have more moderate to severe psoriasis, in this case defined by treatment patterns. And so a cardiologist is going to think about risk in 10-year intervals. So if you look at the 10-year risk of having a major cardiovascular event attributable to more severe psoriasis, independent of traditional framing and risk factors, it's about 6%, which is quite comparable to other major risk factors, including diabetes, which is considered to be a cardiovascular risk component. Cardiovascular disease is the greatest cause of excess mortality in people with severe psoriasis. I didn't mention this earlier, but people with more severe psoriasis die about 5 years younger than they should based on life tables that we created and other risk factors for mortality. It's pretty shocking. No one really has suspected that. We started looking at these associations that's now been increasingly confirmed. And then a recent meta-analysis came out showing that in the United States, from a population point of view, it's probably about 11,000 or so MACE events per year attributable just to psoriasis and not the traditional risk factors. Now, since our work came out, and this is not a slide that's meant to be read, but to give you a sense of the enormous amount of work that's come out since that time, there's been over 20 papers that come out that confirm our research, basically showing in a variety of different settings, different designs, that patients with psoriasis have a higher rate of cardiovascular disease measured in a multitude of different types of ways. Now let's point out a couple of studies here. One is in Denmark, where they studied the entire patient population. They found that patients who have moderate to severe psoriasis have similar risk of cardiovascular disease to people who have diabetes. Again, putting this risk in perspective. And other recent work in the United States showing that the longer you have psoriasis, independent of how old you are, the higher your risk of cardiovascular disease outcomes. We have the sort of dose response, duration of disease, all indicating stronger associations. So we could ask the question, does psoriasis cause cardiovascular disease at this point in time? And many of the standard criteria are in fact met. You know, sort of Stalin and whole criteria we use to assess causality for smoking and cardiovascular disease, for example. But the main issue is that, like most cardiovascular risk factors, the relation may be clinically significant, but the relation is still pretty modest. So smoking in lung cancer is an odds ratio of about 10. Smoking in cardiovascular is about 1.5 to 2. And so we know smoking is a causal risk factor, because if you quit smoking, your risk of cardiovascular disease goes down. So we don't really know what happens when you quit psoriasis, or at least treat psoriasis. Try and figure that out. So in my view, severe psoriasis clearly predicts cardiovascular disease and mortality, but more data is necessary to prove this causal relationship. And so what we're really working with our colleagues now, especially in the United States, where the dermatologist may be the only doctor caring for the patient. Who's 40 years old, 45 years old, have bad psoriasis. It's their main health concern. They don't see their GP. And in our practices, this may surprise you, we don't take blood pressure. We just don't. People, sometimes people are shocked to hear that. We never do that. Increasingly some of us do. But the recommendations are to make sure at least they're up to date with age-appropriate screening, things like blood pressure screens, diabetes screens, cholesterol screens. This is an emerging question whether we should be more aggressively managing our lipids, though, to lower the risk of cardiovascular events. So for those of you in internal medicine, this will be a very familiar slide to you. This is from the adult treatment panel. 3 goals for lipid management. And so you think about people in different categories of risk. You either have a 10-year risk of 10% or less, low risk, and your LDL goal is 160, but your intermediate risk or high risk, you have lower LDL goals. And then so ATP tells us again that, that major risk factors are very important, but they only account for about half the variability in coronary risk in general populations, so we know we're missing a lot of information. And for emerging risk factors like psoriasis, for example, we're advised they can be used as optional modifiers for therapy in order to adjust the estimate of absolute risk obtained with the traditional cardiovascular framing hand model. So there's been several consensus statements that have come out since this work appeared. One in the American Journal of Cardiology, one from the National Psoriasis Foundation. These were geared on screening, sort of trying to make sure patients with psoriasis are up to date on the appropriate screening. There's a lot of studies that emerged showing very high frequencies of underdiagnosed diabetes and underdiagnosed hypertension. But taking a page out of the rheumatology book, the European League Against Rheumatism, they suggested that someone with rheumatoid arthritis should have a multiplication factor added to your risk score. So whatever that risk score is, multiplied by 1.5, and that should be their new adjusted score. And they have this, probably less data than we do in severe psoriasis at this point in time, in terms of the impact of disease on cardiovascular risk. So one thing that we've looked at is, I talked about it before, that attributable risk estimate over 10 years is about 6%. And so if we take a group of people with seen in a preventative cardiology practice, most of them are very young. That's why people are so many are at low risk. Blue is low, medium's teal, and red is high. And you see for the Framingham risk score, most people, men and women, are both at low risk who have common with psoriasis, being so young. But if you add the 6%, about half of patients end up being in the more moderate category or going up to the more high-risk category. And that would change management. In many cases, being more aggressive with therapy, lifestyle change for patients first, and possibly with pharmacotherapy or cholesterol. We'll move on to the metabolic aspect of psoriasis now. You'll all be familiar with metabolic syndrome, a cluster of cardiovascular risk factors, obesity, hypertension, dyslipidemia, insulin resistance. And this is a pathogenesis slide from one of our journals by our leading researchers showing the striking similarities and overlap between metabolic dysfunction and psoriasis. So many of the cytokines that are elevated in psoriasis impair insulin signaling, for example. And so much of this work initially started on obesity. It became very clear to us as we were looking at our patients and trials that the prevalence of obesity was dramatic. And so large studies from the Nurses' Health Cohort out of Boston have shown that obesity actually is a risk factor for developing psoriasis. And other studies out of Rochester, Minnesota, have shown as the obesity epidemic has increased in Rochester, the incidence of psoriasis has increased in parallel. They estimated that about 1 out of 3 new cases of psoriasis are related to being obese. And more strikingly, surprisingly, the recent data has emerged in children, kids who are on average age of 10 with psoriasis, have prevalence of metabolic syndrome of 15 to 20%. and the control group was 0. So who would think that, who's 10 years old, it's metabolic abnormalities, but when they have psoriasis, they are much more likely to have these issues. This is newer data from our group. It's a cohort study funded by the National Heart and Blood Institute. It's called the Incident Health Outcomes and Psoriasis Event Study. If you're doing cardiovascular outcomes work, you have to have acronyms. I spend most of my time doing acronyms and some time doing data analysis. And so what you're looking at is basically the general practitioners, is 9,000 patients who have psoriasis in the UK, a similar system. Where we ask the GP, just tell us what their psoriasis typically is. Is it less than 3% body surface area, mild disease? Is it 3 to 10%, or moderate disease, which is more than 10%? And you see from these very simple classifications from untrained general practitioners, it has prognostic value, what's going on in their blood and on their scale. They have a dose response and their odds of having hypertriglyceridemia, hyperglycemia, and of course obesity. These are all independent of one another, adjusting for all the risk factors for hyperglycemia, for example. So you can't look at your psoriasis patient and say, well, you're thin, I don't have to worry about metabolic disease. No, this is controlling for body mass index. In fact, even controlling for that, the more severe the skin disease is, the more likely they are to have dyslipidemia occurring in their blood. Taking that to another level, we then want to understand the risk of frank and overt diabetes, known as metabolic syndrome, puts people at risk for developing diabetes. And here you can see these clear dose responses from our group and Multiple Nurses Health cohort in the US, Health Questions Follow-up Study, basically showing a mild group, a smaller association, a larger association, more severe psoriasis. When you adjust for obesity, some of this attenuates, but doesn't go away completely. Okay? So showing that this residual impact of disease on the risk of diabetes and psoriasis. And in Nurses Health Study, the Health Questions Study, here they can control for every risk factor known for mankind, diet, exercise, all of these things. And this is a more general population of patients. They see about 25% higher risk of diabetes in people who have primarily mild disease. We've done some much more sophisticated work recently in collaboration with a colleague of mine, Nehal Mehta, who's at NHLBI, and Dan Rader. Dan's a pioneer in lipid metabolism research, also heard up widely. And basically what we looked at is the impact of psoriasis on HDL function, measured by HDL efflux. So some of you may be aware that HDL is good cholesterol because it removes cholesterol from arteries. And those assays have been developed to tell you how well someone's HDL is functioning, and is it actually cardioprotective? It's a clear risk factor for coronary disease when not functioning properly. And so people with psoriasis have dramatic reductions in how well their HDL functions. So when you draw lipids on their HDL is 60, and you're feeling good about it, that's not telling you the whole story. Their HDL may not be functioning well, and therefore may not be as cardioprotective. Same thing with their LDL. When you look at their LDL by nuclear magnetic resonance, you see that they have an increase in particle concentration, decrease in particle size. This means that pound for pound, their LDL is much more pathogenic than a typical person who doesn't have psoriasis. So as we emerge this concept, something of it as a sort of psoriatic march, if you will, has come out of European literature, where basically you have psoriasis, you have this chronic inflammation, you develop insulin resistance, you develop dyslipidemia, and this is part of the pathway towards coronary disease and myocardial infarction. So what's the clinical significance of this in terms of metabolic issues? Well, there's several that it's important to be aware of. So one is patients are worried about their children developing psoriasis. So one thing we can tell them, although you don't know empirically this will work, is that maintaining a healthy body mass index may be important for preventing or lowering risk of developing psoriasis in the future. So they are worried about their children developing it as a healthy lifestyle to try and encourage. Screening for diabetes and lipid disorders, especially more extensive psoriasis, I think is very important given the emerging data that we and others have shown. And what I find in my practice, I do a lot of hemoglobin A1Cs. It's hard for me to get fasting blood work because I usually come to see in the afternoon. I just want to draw the blood work down. And many of these patients are pre-diabetic. Many of them really exhibit metabolic syndrome, whether they're obese or not. And for those who follow this literature, you'll know that therapeutic lifestyle changes can lower the risk of overt diabetes. There's also pharmacological approaches, metformin, for example. So the opportunity really here is to identify a patient with a higher risk of developing diabetes and intervene into lifestyle changes pharmacologically ways to try and lower the risk of that patient developing overt diabetes. Obesity also, and metabolic disease also alters the risk and benefit profile of our therapies. So this may not be relevant for the general practice community, for dermatology, certainly is. Many of our non-weight-based therapies, be they biologics or methotrexate, don't work as well on people who are obese. So they're therapeutically challenged to deal with. And the other issues are standard bearer, methotrexate. Our big concern is liver toxicity and chronic use of methotrexate. And based on our guidelines and other lines of evidence, fatty liver disease, obesity, diabetes, all risk factors for developing cirrhotic changes from methotrexate. So this is a real clinical problem for us. So many of our patients who need methotrexate have fatty liver disease and other risk factors for liver disease that confound the management of methotrexate. So after all this information, we can sort of ask this question. This is outdated slide, so I should say 2013. Okay, so in 1970 or before that, 1960s, there was lots of controversy about hypertension, whether that was really a risk factor of cardiovascular disease or just a commingling risk factor that needed to be treated or not. And it wasn't until the VA trial was done that paradigm completely shifted. You lower systolic blood pressure, you lower the risk of stroke. This is actually really nicely summarized by an article by Fees in the Journal of Hypertension a couple decades ago. So in 1970, we learned that hypertension was a silent killer. In 2004, this is a popular magazine. Magazine's inflammation is now the secret killer. It promotes Alzheimer's disease, cancer, heart attacks, metabolic problems. And so in 2013, it surprises maybe the visible killer. This stares us in the face as dermatologists in practice all the time. Most of our patients we don't have effective treatment for, or we fail to maintain long-term remission. And we really can't tell our patients at this stage, should you, treat this disease to try and lower the risk of other morbidities at a time, or if it doesn't bother you, just go along and live with it. We just don't know what the right answer is yet. There are hints from the literature that vaccine may make a benefit for these patients. So for methotrexate, there's been a meta-analysis mainly in the rheumatoid arthritis community, about 20% reduction in cardiovascular events in those on methotrexate already, compared to those already not on methotrexate. And this data was compelling enough that the National Heart, Lung, Blood Institute is running about an $80 million trial right now for patients who have high risk of cardiovascular disease but don't have any other health problems like skin disease already, and putting them on methotrexate in an RCT format to see if targeting inflammation directly would lower the risk of cardiovascular events. And that would really add a lot more information for how we think about our patients. And then TNF inhibitors, a major class of therapies for psoriasis, inflammatory bowel disease, and RA. There's over 13 studies that have meta-analyzed about 50% reduction in cardiovascular risks in patients on TNF inhibitors, and if you ask the question whether or not that would be confirmed from our success. What about in psoriasis? Well, here the data is really just emerging. There's two nice studies, one from the Kaiser group, and one from Denmark again, showing about a 50% reduction in cardiovascular risk in people who are on either TNF inhibitors or on methotrexate in terms of their cardiovascular event outcomes. We also have a couple of studies that have not confirmed the benefit for these therapies for cardiovascular events. Most of these were either underpowered or had other methodological issues that really didn't address the issue. But I will make you aware of a recent meta-analysis that came out in JAMA, suggesting that a new class of drugs is IL-12/23 inhibitors, TH17 pathway inhibitors. There was a signal where there was, I don't remember exactly what it was, maybe it was about 5 or 6 cardiovascular events in those who got the drug compared to placebo where there were no events. This raised alarm that, in fact, perhaps this class of immunological therapies could increase cardiovascular risk and not decrease. And this reminds us that it's a lot to be learned about how the immune system modulation affects cardiovascular risk. So I think where we are now is we don't know the answer. We've gone from lots of observational data, population-based studies, we've validated multiple different populations, showing complete dose response, clinical significance association, but we need RCTs to move the field forward. So this is a trial we're engaged in now. This is funded again by the National Heart, Lung, Blood Institute. And so what we're doing here is our major output here is vascular inflammation measured by an FG scan, radiolabeled glucose merged with a CAT scan. So we can anatomically localize and quantify how much inflammation is going on in the vasculature. I'll talk more about that in a minute. So patients are randomized to a TNF inhibitor called Analygements, or just treating their skin, ultraviolet phototherapy. Because the question is, if we treat their skin, maybe we'll lower systemic inflammation in the vasculature. We don't know the answer to that. Or they're getting placebo, and they get a scan at baseline at week 12. This is a randomized 400 period, and then they have an open label period for a year to see if more chronic therapy with TNF inhibitors makes a difference in these endpoints. And we'll also look at lipid metabolism, HDL function, and LDL particle size to see if we can reverse things with these different treatments. And what is FDG PET-CT? Well, this is a pretty exciting technology. It's increasingly used by the FDA as an early surrogate marker for cardiovascular drugs being developed, not targeting LDL, but targeting vascular inflammation as another way of lowering cardiovascular risk. What's nice about this technology, what we're looking at it is it's basically superimposed hotspots, radiolabeled glucose uptake in the aorta. This patient with a CAT scan is on top of localize it. It's highly reliable. It's predictive of future cardiovascular events, even independent of traditional risk factors. And it's modifiable. So in RCTs from Japan, you put people on the statin, in 12 weeks, you've seen significant reductions in vascular inflammation. You put on therapeutic lifestyle change for about a year, you see reductions in vascular inflammation. So it's a pretty nice model for looking at cardiovascular risk. And in our own preliminary data, when we looked at vascular inflammation in people with psoriasis, we actually found that they had about 2 decades of aging in their vasculature of inflammation more than control. It's much more activity than expected based on their age and their existing cardiovascular risk factors. And others confirm as an insurance disease like rheumatoid arthritis. So interestingly, some data that I don't have publicly yet, some of the data suggests that people with psoriasis have more vascular inflammation than those with RA, which would be surprising. This now is just some sort of interesting data from early patients in the study. People were randomized to phototherapy on. Phototherapy is pretty hard to blind, so that's open label. And so what you're looking at is radiolabeled glucose uptake in the skin of these patients. You get a sense of how much metabolism is going on in these people. So the redder it is, the more metabolically active the skin is. Most likely this is due to uptake by monocytes, but could be keratinocytes. And after he had most of his skin cleared, he has about a 3/4 clearance for psoriasis, what we call positive 75. You see residual skin disease here. You see some residual inflammation, but certainly much better than he was when he started his study. And so the question is, what's going on way up over here? What's going on in the aorta? That data we're not analyzing yet. We'll analyze that once all the data is in and do that in a blinded manner so we can be rigorous in that. That's really the key question. We know we can improve disease locally, and we do things systemically. So, in conclusion, I hope I've shared with you today an extensive literature suggesting psoriasis may be an independent risk factor for cardiovascular disease, as well as an increase in literature looking at diabetes as well. Studies evaluating the impact of treatment of cardiovascular metabolic risk are urgently needed, and they're ongoing. There's lots of studies out there now taking it to this next level. And that being said, people with psoriasis today should be educated about cardiovascular risk and undergo appropriate preventative procedures. So I'll close there and acknowledge the funding I received from NIAMS and NHLBI, as well as from the variety of foundations, and also all my collaborators, postdocs, textures, and my postdocs helped a lot with the IQ trial, and food docs and coordinators. Thank you so much. Wonderful honor to speak with you today. So I apologize. I do speak fast. We got a lot of information in in about 50 minutes. We do have some time for questions.
I have a two-part question. You mentioned in one of your earlier slides, both are venous thrombosis. And the first part of the question is, what about antiphospholipiid antibodies and venous factor? The second part is, how big uric acid levels as cardiovascular association and uric acid is that help? And finally, just information you say, arthritis, lupus, arthritis, etc., is associated with this
Right, so there's all aspects of this first about antiphospholipid. It's the same question that was good. So if it's by uric acid, that's
Related to the arthritis questions, does the presence of psoriatic arthritis in patients with psoriasis change the risk of cardiovascular disease and this type of arthritis?
Yes, it's a very important question. One is, so people with psoriasis with larger psoriasis and they have more severe psoriasis. But the severity of your joint disease is not correlated with the severity of your psoriasis. So,
The rheumatologist in Toronto was really one of them. Right when we found in our cohort who were very active, severe psoriatic arthritis, that severity of skin disease was one of the most important prognostic markers for So the data is a little more mixed with psoriatic arthritis alone. It's a different risk factor for coronary disease, but some data will support that. In our own studies, we know if we pick out factors, PSA, and arthritis, this.
Thank you very much.